you just like to describe the difference with what phase you're at and what that means for our participants?
Sure. So at Crinetics, we're developing a compound, and I hope if you go back and look at Chris Cook's presentation from this morning, or our booth stop by. But it's essentially, it should work for diffuse patients, and we think the mechanism will apply to all patients. It's targeting to be a once-a-day oral drug for children with hyperinsulinism. Right now, we're getting ready to submit all our first-in-man enabling documents so that we can test it in healthy volunteers first. That should be early next year. And then 9-12 months after that, we would hope to be able to go into patients.
Great. Anyone else have something they feel would be appropriate here? Any clinical studies you have going on at your facilities that might involve diffuse individuals? Great. Ty, do we have another question?
We do. So is there more option of medications for HIHA kids if Proglessum is not working?
Oh, let's see who wants to take
Starting
that.
easy.
Any other options for other than diazoxide for HIHA? One of our clinical folks want to take the first stab at that?
Well, I can just MJ. I can start to. I'm sure other people will join in. It's just that there are not many medicines available at the moment, so it is really difficult. So you'd have to work at the dietary angle and try and reduce the protein load if possible, and you know, work on increasing carbohydrates to protein and what works best for that child, if you're absolutely convinced that Proglessum is not working. But there is some research that's happening. I'm sure my colleagues in CHOP could fill in that.
Great. Any other?
Hi, this is Pratik. I just wanted to share, yeah, I mean, diazoxide would generally work. Maria is here, so we've just kind of collected a series of, you know, as Indy said, there's not many medications, but diazoxide would generally work. But in one of children where diazoxide did cause severe side effects, and trialed lanreotide, but unfortunately there's not many oral medication, or there's no oral medication. So there are, you know, other medications as what we would use in chai. But yeah, that was my experience of using lanreotide in protein sensitive.
Since the question was about hyperinsulinism, hyperammonemia syndrome, I do want to mention we do have multiple studies ongoing for children and adults with hyperinsulinism, hyperammonemia syndrome, ongoing at the Children's Hospital of Philadelphia. So if you visit our booth, you can learn more about those studies, and please do contact us.
Great, thanks, Dr. De Leon. Ty, did we want to open the door? I see there's a question from the audience now.
We have a question ready to go next, and I just want everyone to know that we will do our best to answer as many questions, both from our breakout groups and in these larger sections today. But if we are not able to answer all of them, we are collecting everything that is put in chat, and we'll do our best to follow up with everyone in follow-up materials and all of that. So the best thing you can do for me is, if you do have a question, type it out in chat, and then I will ask if you are comfortable asking it live. And we have a question from Brian, who is going to get us started with some live questions now. Brian?
Sure. Hi, I wanted to ask you guys a little bit about what the holdup is on the capsule dosage of diazoxide in the United States. I understand it's available elsewhere, and I don't know if the holdup is in research, or is the FDA requiring extra bioequivalency studies on the formulation differences? And I just wanted to see where we're at with that. I would certainly like to have Sam to have some more patient-centered options as he grows older, besides just the suspension. So what do you guys think?
Julie, you want to talk about your efforts?
Sure, sure. Yeah, so Brian, you've actually pushed me a lot on this. It's not the first time.
Sorry about that.
No, it's good. It's all good. So luckily, there's a new player on the block, a new company, E5, we were just talking about it in one of the breakouts. And they are now developing a generic form of diazoxide, Proglycem, and they also are interested in developing the capsule to be available in the US. And they're looking into, you know, what that will mean for them financially. And it is kind of difficult because we've all concluded it's not really going to increase use that much in the United States, but we still want them to do it because it's the right thing. And if they don't lose money, then, you know, they're willing to do it. And, you know, given your background, you're a great person to have on the team. Brian is a chemist in addition to being a parent. So we need you on this team. I'm going to connect you directly with the president of the company. Push him.
Great. So I did see a question and I didn't want it to get missed. This is for Dr. Betts. It says, is there any information about expected side effects for the SST5 yet, specifically how they compare to the lanreotide, octreotide side effects?
That's a really good question. I won't go into our like hour-long talk discussing the differences between SST5 and SST2, but in general for the side effects, especially kind of probably the GI side effects, I think probably they're referring to, I kind of expect them to be kind of similar. And I would expect them to be similar to the short-acting octreotide side effects that you might see when people were given the short-term injections. But we'll know more when we start our phase 1 at the beginning of this year.
That's why we need everybody to participate in the clinical trials, because that's the only way of learning this information.
And what I saw in follow-up was the same for our other biotech and drugs. So why don't we just go around? Brian, I see you typed an answer, but would you mind sharing that for RZ358? And then Clara, I'll go to you for the dasiglucagon.
Yeah, I wasn't sure if maybe it was an extension of an earlier question about diffuse disease, and it was asking about post-pancreatectomy and whether that would be okay. So if the question was a follow-up in terms of trial eligibility, at least in our case, we are, if other eligibility criteria are met, we are permitting patients who have diffuse disease and/or who have had pancreatectomy as long as they have residual or persistent hypoglycemia based on the evaluations that we do during screening.
Great. Great. And then I see on here, are there any side effects of the dasiglucagon? So Dr. Owen?
Yes, so dasiglucagon is a basically copy of the natural hormone occurring in the body, which is glucagon. So it would have a similar adverse events like glucagon. For instance, nausea, sometimes even vomiting, a loss of appetite would be something that we would expect glucagon and dasiglucagon will share. There's some effects that we also following on heart rate and blood pressure. They also are shared with what glucagon does in the body and what dasiglucagon would do. And the third area which we are following in the clinical program is issues with skin findings, because glucagon is a hormone that works in amino acid metabolism. When you're repairing your skin, you need amino acids to be available. And glucagon and dasiglucagon might interfere with that. So those would be the things that we're following in the clinical program, and that once we are ready to report our first clinical trial, we will know much, much more.
Ty, do you have any questions? I see so many coming through. I'm just going to let you completely field them.
Yeah, so I think one, sorry, I just lost it. So we have a great question from Trent and Candace here. Based on what we have seen with COVID-19, how much risk is there to supply chain for diazoxide? And I think it's a great question in general if we want to expand it out, supply chain. And, you know, again, we know this is hard to talk about, but disruptions.
I guess I'm not sure we have the perfect answer for that, other than Julie, in your conversations with folks, have they been talking about supply chain issues?
Okay, I was desperately trying to get Henrik Christensen in. So supply chain issues generally for the drugs currently. But yeah, okay, so there's a huge problem for a lot of people outside of the United States. As Diva quoted yesterday from our study, there are problems with, I think 60% of those who responded said that they have trouble getting diazoxide to their patients. So we cannot forget that, you know, that is with us and we're all working on that. In the United States, Teva had told me, they promised me there were no supply chain problems, and now we have E5. So I think that we have a lot of diazoxide in the US right now. The others, I think, you know, I can't really speak so well. There were big problems last year in many countries with diazoxide, sort of more than typical, because there were some makers that weren't making it. So is Senthil with us? Senthil could tell you that, I don't know.
Right, Senthil was the person I was going to next. Senthil, are you available to answer?
Yeah, sure.
Your experience with the supply chain?
So we had some discussions in the previous session actually on the resource limited settings and the issues with the medications. So there's been a generic problem with availability of medicine in countries like the South Asian countries and some Eastern European countries as well, which has been exacerbated by the COVID situation. So it is an issue. It's actually slightly worse at the moment in the current COVID climate. But I know Julie and the team are trying their best to help, but especially that specifically with diazoxide, getting the diazoxide preparations.
Dr. De Leon.
I was going to mention that right now I'm not aware of any shortages about diazoxide, as Julie mentioned, but there is a shortage of the diuretics that we use in the United States for the patients that are on diazoxide. So we are in the process of, for patients that need to refill the diuretics, Diurel is what more frequently we use, and it's right now a shortage that we hear would not be resolved until much later this year. So if you are in that group of patients that are on Diurel, you need to talk to your physicians so they can find a replacement. And there's a replacement. The problem is that replacement comes only in capsules and tablets, so it will be a little bit more difficult to find the right dosing for the smaller children, but it's a discussion to be made. I don't know if it's related to COVID or not, but that's a currently ongoing situation.
Ty, what do you, Indy, go ahead, please.
Just to say that some labs will actually do special formulations of diazoxide, certainly happens in the UK, but the quality control is not reliable in all of these special preparations. So Teva, I know they are quite expensive and they have almost a monopoly on it, but we stick with that formulation because it is FDA approved and the quality control we know is absolutely perfect. So although special formulations are available, I would not suggest unless you can have a good QC quality control data on that product.
Got it.
Davelin, we have a question live here from Janet. Janet, you can unmute yourself and go ahead.
Hello, I just wanted to know how adults who are no longer under the International Children's Hyperinsulinism Centres can continue to find out about research and trials and participate in them if they're not under one of the centres. And of course, children and young people throughout the world who aren't under special centres.
So I'll start with that answer, Janet, and then if anyone else wants to add. I did see, Brian, thank you. You gave a good source in their beginning to answer, and that is typically there are, and I didn't see, Brian, if you had mentioned the EU, but I know in the US we have clinicaltrials.gov. I'm sure the EU has something similar that tracks theirs and can help. Obviously, as much as Congenital Hyperinsulinism International is aware of them, we put them in social media and in our support groups. And as I had mentioned earlier, through HIGR, as we are working with clinical trials and using their inclusion and exclusion criteria to help identify potential participants. For those that are a part of the registry, we'll be receiving notifications potentially of trials that they may be interested in or qualified for, that they can reach out and then learn more from the biotechs that are running those trials. So that is kind of a general response. Does anyone have anything in addition you would recommend? Okay.
I think I'm just going to say that, young adults and older adults with HI are relatively rare because nobody picks them up and they're outside children's hospitals and children's services. So I think if you could put in something around social media for these young adults to come back into the HI fold would be very, very welcome.
Ty, do we have another question?
We do. Oh, am I on mute? No. We do. I just was asking if Ben would be willing to ask live, and I haven't heard from him, but I'm making him, if he would like to ask, and if not, I will. Go ahead, Ben.
Yeah. Posted 2 questions. Which one?
Oh, yeah. Your first question, about the bionic pancreas is the one I saw first. So go ahead.
Cool. So, when do you guys think the release date for the bionic pancreas will be for people to use it?
Dr. Damiano, you want to
Thanks, Ben.
answer? Thank you, Ben.
Yes, thanks, Ben. So we are right now enrolling into a pivotal trial, what the drug companies would call a phase 3 trial, with the insulin-only configuration of the bionic pancreas. So we've got 16 clinical sites across the U.S. that have enrolled now 440 subjects. Through COVID, they were able to figure out how to do that. It was a pretty Herculean effort. And so we have our cohort lined up, and we have one more application in front of the FDA right now. In the next 30 days or so, we're hoping to be able to begin putting people on the device into that trial. So we're hoping in the first half of next year to have the market application submitted for type 1 diabetes, and hopefully have clearance of that device by the FDA around this time next year. However, in terms of a glucagon-only configuration, it's something that we're working with Zealand Pharma on. We certainly would like to see an opportunity to bring the iLet in a glucagon-only configuration to people with pre-pancreatectomy CHI. Maybe around that time could be possible, depending on the timing of their study when they'll be finished. But certainly next year is something we would like to target. As for a bihormonal system for adults with CHI, that is probably a little bit longer. So that's more like a 2022 kind of event for people with type 1 diabetes, but also I could see a similar parallel path for the bihormonal system in CHI, post-pancreatectomy CHI. So think we're looking at, 12 to 24 months, depending on which of the 3 configurations you're talking about.
Great. Thanks, Ed. Ty, any other questions?
Yeah, I received one earlier. For HIHA patients, will diazoxide and diaryl, will it be for life?
I think Charlie Stanley should answer that. So since
Right, I was
treating this patient for longer.
I was looking at the list.
The HIHA is sort of unlike the more common ABCC8 kind of hyperinsulinism, which tends to get better as with age, where HIHA patients continue to have hypoglycemia into adulthood, and most of them continue to require diazoxide. And I think the oldest patients that I know of on diazoxide are probably now in their 60s. And the problem is, of course, that there's no alternative at this point to diazoxide.
I just want to add something to that, if I can.
Sorry, I muted myself. Yes, Cynthia, please go ahead.
Thank you, Professor Stanley. I'm nowhere near the experience of Professor Stanley, actually, but we recently published a patient with HIHA syndrome who has actually managed to come off diazoxide at 8 years of age. I was genetically proven HIHA and was on small doses of diazoxide, and we then managed to stop, and the patient subsequently fasted normally, and the protein load test was normal as well, and no more ongoing hyperglycemia. So whether it is I don't know, mild mutation and the patient was quite lucky, I don't know, but the majority of patients will end up needing diazoxide in the long run. But looks like there may be a few patients who may be able to come off treatment.
Yeah, it seems like some of the patients are able to tolerate the fasting a little better as they get older and mainly have problems with the protein. So there are some kids who, if you go on a low protein diet, and you make sure that they carb load in a 2-to-1 or 3-to-1 grams of carb to protein ratio, that you can prevent the hypoglycemia and they can come off the medicine. But some of them continue to have significant fasting hypoglycemia. So it really depends on how much the balance is between the protein induced or the fasting as to whether you can get some of the kids off or not.
This is Charlie Stanley. I just wanted to emphasize what Dr. DeLeon talked about earlier, which is that at Children's Hospital there's very active research, and specifically on the patients with HIHA, to look for new therapies and new clinical trials and research projects underway. So if you're involved with HIHA, you should maybe contact Dr. DeLeon.
I was wondering when this question was going to come up.
Do you see the two about pregnancy?
Yes. So this is one. Yeah, this is one that actually has been asked, I think, at every Ask the Expert panel for the last few years. So Ty, you want to read that?
Yeah, so 2 related questions. As some of our kids are nearing childbearing age, it's clear that diazoxide, people want to know if it's harmful during pregnancy. If it is, what their choices are.
Dr. Monarchy, do you want to start?
Yeah, yes, I have a lady seen with a familial dominant hyperinsulinism, but we have no cause of this, but she was treated when she was 3 years old, and when she was, I think, 24, 25 years, she was getting pregnant, and she has stopped the diazoxide, and we treated her with octreotide for the whole pregnancy, and then later we started diazoxide again. So, but it's only one case. So I'm not sure if this is one can recommend, but what I read about substances like diazoxide, I thought there might be some toxic effects, and with the somatostatin, it looks for us more convenient in this case. But as I said, it's only one case.
Dr. Thornton.
Yeah, so I also had an adult woman who got pregnant. She had, I can't remember if it was HNF1 or HNF4 alpha. It's just gone out of my head at the moment, but she had one of those two forms of hyperinsulinism, and she got pregnant at the age of 35. And we stopped her diazoxide as soon as she got pregnant and treated her with octreotide. And it wasn't perfect, but she got through the pregnancy. The baby had the same mutation, but did not get hyperinsulinism and had a good outcome. So that's two pregnant ladies. So maybe Klaus, you and I will get together and we'll write them up.
Okay.
I would like if one of our biotechs can talk about, since this Ask the Expert is about research, why or how or what steps do you as in drug development have to take to get an indication or to know that it's safe to use in pregnancy? I think that would be something very useful for our patients to understand.
Yeah, if Alan's on, I think their programs are most advanced. So that's with their acromegaly program, maybe. So that may be the, he may be the right person to respond, and I can add to that.
I think Alan's popped off here, but essentially there's a very, at least for the FDA, there's a well-defined pathway of reproductive toxicology tests that you have to do over the course of the development of your molecule. And so that can be done either before you go into the clinic, but more often it's sometimes done while you're in the clinic. And we talked earlier in a couple of sessions about inclusion and exclusion criteria for certain patients. And until those tests are done, you would typically exclude a woman who was pregnant or was likely to become pregnant. And only after those reproductive toxicology tests are done and analyzed and shown to have a nice margin of safety, would you then start to dose into women who are either pregnant or likely to become pregnant?
I would agree with that, with one slight caveat. Sometimes in trials, you can still enroll women of childbearing potential, as we call it, as long as there are extremely effective means of contraception used.
Yes, exactly.
Depending on the stage of the program. You know, the later stage, obviously, we have to be a little bit more real world and open up trials more. So, but Stephen is right. As the program advances, we tend to gain more information on reproductive safety. It generally isn't there earlier in programs.
And I can also echo that. I mean, we are in a phase 3, and we're conducting our pivotal trials, and we still require girls enrolling into the program to be on an effective means of contraception. Having said that, of course, as soon as the drug is released and used in the market, the manufacturer of the drug is under expectation for reporting any pregnancies and following up any pregnancies that happen whilst the drug is being used. So the data collection is to start with kind of anecdotal, and at a certain point might be turned into a prospective trial, testing and checking that the use of the drug is safe in pregnancy, but that tends to come quite late in the life cycle of the drug or the use of the drug.
Evelyn, you're on mute.
I know. I've hit the mute and unmute button so many times, I'm not sure what it means anymore. Thank you. I think that's and it's such an important part as we talk about new drugs and focus on that there is a growing population in our community of young women and men. So we want to know about gonadal issues as well. But there are a large number of young women who are not able to even think about what it would be like to be pregnant and have children, or if so, what they feel very isolated and alone in that decision making. So I think understanding with new drugs coming on what it takes is also a very important part of their kind of hopes and dreams moving forward. So that's something I've heard for years. I thank you all for offering or adding to that. Ty, do you have, I'm sure there have been lots of other questions while I was kind of listening to the responses.
Yeah, I am allowing Carla, you now should be able to unmute yourself and ask your question.
Yes, hi everybody from Dubai here. I wanted to ask a question about the Cure Fast. So my boys are HI, ABCC8, diazoxide responsive. Both of them are still taking the same dose that was given at birth. So now they are 6 years old and 8 years old. So how and when we should consider doing a Cure Fast?
Dr. Henriksen, we've not been able to call on you. Would you like to start with this answer?
Hello, Henry. I think that it could be a hint that it has gone milder, the disease, because we usually dose per kilo. And if it's the same dose for 6 years, when the kids are growing, it must have become milder. But it depends very much on how well controlled you are, how is the average glucose value, HbA1c, and what are the glucose values around the clock. If it's time to make a fast test, it's not possible to say just from this question.
Got it. Ty, or does anyone want to add any follow-up? I know we're getting close to the end. I wanted to get to a few more questions.
We have.
Hang on one second. Paul, you want to go ahead?
Yeah, I was just going to say that to me, the first step is do a fasting study on diazoxide. If you're able to show that your child has got normal fasting duration and generates ketones, then you can consider a trial of weaning the diazoxide. And if hypoglycemia intervenes, bring the patient back in, do another fasting study. And if you now show that they no longer are able to fast normal duration and make ketones, there's your answer. You need to stay on the medicine, and then you go back to the first dose. And if you're able to wean off, you keep going till you get off, and then try a fasting study off. So it's a sort of a two-phase system to figure out if someone who's so beautifully controlled that you've no longer seen any hypoglycemia is able to come off. It'll take some time, but that would be the way I would approach that problem.
Thanks, Dr. Thornton. Ty, do we have some other questions?
We have a question here from Marabella. What about patients on lanreotide? How long are they usually on it?
Let's see, Dr. Dastamani, we haven't had a chance to hear from you. Sorry to call on you unexpectedly.
It depends from the response to lanreotide, but if the blood sugars are stable and the children are tolerating appropriately overnight fast for their age, we can gradually stretch the frequency of the lanreotide injections. And when the patient will reach 8 weekly lanreotide injection without any hypoglycemic episodes, absolutely stable blood sugars during daytime and tolerating appropriate fast overnight, then we can bring the patient in for another control fast before the lanreotide injections to see if the patient is capable to tolerate appropriate fast for his age and generate ketones, as Dr. Thornton mentioned, and then to advise to stop lanreotide. Of course, we will still need to continue to monitor the blood sugars regularly after stopping lanreotide, but we have a few patients that they came off lanreotide.
Dr. Conwell, any other management keys that you do there in Australia or from your perspective?
With respect to lanreotide, I mean, we certainly have a number of patients utilising the short-acting octreotide, either injections or in continuous pumps, but also that have made the transition to lanreotide. I've pleasingly had a couple of patients come off recently. So one in the context of a diffuse homozygous potassium channel mutations, he came off at around 5 years of age, and he'd had an earlier near total pancreatectomy, and another little girl, a toddler with Beckwith-Wiedemann syndrome, who was able to come off recently. So again, I think it depends a little on the clinical context and the underlying cause, but again, ongoing monitoring and obviously also watching for any trends to increase glucose levels, particularly after eating.
Sorry, I was muted. Do we have time for one more question?
We do. So I'll just ask in the interest of time. So do you have any advice for older children transitioning to adult endocrinologists? Our pediatric endo said he will keep seeing her, but unsure how long he can actually do that.
Dr. Malikian, we haven't had a chance to hear from you. Would you like to start answering?
Thank you. Hello. My cohort in our country is quite young. So I have only a few patients who are older than 18 now, and I still keep following them as endocrinologists. But yes, of course, there should be adult doctors for those patients too. But this transition period is quite hard. We need to find adult doctors to work with those patients.
And Dr. Shah, I know you have had some experience with this. Would you like to share what you've done or what you've seen?
Yeah, so this was one of my sort of passion to look into transitioning young people, you know, and it is really important to actually have, now it is kind of becoming more evident that we've got young people and adults with hyperinsulinism. So it is a key to actually have somebody who we can share the expertise. So, you know, to kind of have that, I think it depends on obviously which country it is and you know what kind of resources is available. But it is equally important that we have to realize, and you know, in adult endocrinology is a very different world than what we have in pediatric endocrinology. So when we actually transition the young people, we do know that those young people do require a lot of support in terms of community support or feeding support or psychology support. And what actually I found was, you know, psychologists actually play a really, you know, good role, but unfortunately in adult endocrinology it is not easily available. So I probably would say it is important to start talking with your pediatric endocrinologist a bit early on, if possible, from about, I would say 13, 14 years of age if possible, but at least start planning ahead. And it's always useful to have a team, full team who you could actually see, but unfortunately that's not always possible.
So just in the very last few minutes here, we'll push it, and it looks like this might be a good one for Mark. Are there any treatments or research being done for HI kids with digestive GI issues, especially around vomiting feeds?
Yeah, it's becoming an important area for us to be looking at in Manchester as well. The mechanisms are quite complex and varied, I think, from all of the adaptive measures that will be taking place in a child as they sort of learn to sort of take manual feeds, but also some of the intrinsic defects that we have in children with hyperinsulinism are replicated in different parts of the central nervous system and the GI tract as well. So it is an area that you know, several groups I think are becoming more active in, and we will see some strong progress in this area. Yeah, it's a good question.
All right. Thank you, Mark. I'm glad that we were able to. And sorry, Dr. Flanagan, I think you might be the only one that didn't get a chance to come off mute with no genetics questions, but I do appreciate you being here always. We are at time for this session. Ty has busily, I can hear and see her fingers wiggling. I know that she has captured all of the questions that everyone has asked if we didn't get a chance to ask them live. So we will work to get answers for all of the questions that those of you who have asked throughout the conference the last couple of days, and work to get those answered for you. So thank you to our experts for sharing your experience and your knowledge and expertise. I think what we'll do is we will all turn our cameras off.
Actually, if I can interrupt, Evelyn, we would love to see all of you enjoying this live performance.
Oh, it's the opposite. Okay, sorry, everybody.
That we can't see all 116 people or 139 people in the meeting. So for those of you at home, if you want to take a video or an Instagram story, we loved seeing your faces yesterday. So we would love to see how you enjoy our live performance. And with that, Julie, should I come to you or just send it over to Jana?
Send it over to Jana, but experts, we now want to check out your expertise in chair dancing. So performance is happening. Please exercise your chair dancing expertise.
Yeah, if you have turned it off, turn it back on.
Hi, everybody. Everybody can hear me? I hope so. I hope you guys got a chance to look at the video yesterday. If not, it is in the conference website in our Chi booth, and it's also officially on YouTube now. So enjoy and sing along if you can. If your sugar's low and your insulin's high and you don't know why, it might be HI. If your sugar's low and your insulin's high and you don't know all right, all you sugar babies and all you sugar parents and all of you sugar kids in between, sugar young adults, are we ready to ride the HI roller coaster? 1, 2, 3. Sugar goes down, 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 so we gotta bring it up, up. Sugar goes down, 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 so we gotta bring it right back up. Most of the time, the sugars are fine. Sometimes it goes low. You could be running, or playing, or dancing around. Or sometimes we just don't know. Yes, sometimes it takes us by surprise. When we've got mommies and daddies by our side, holding on to us for this roller coaster ride. So if your sugar's low and your insulin's high and you don't know why, it might be HI. If your sugar's low and your insulin's high and you don't know why, it might be HI. Sugar goes down, 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 so we gotta bring it up, up, up. Sugar goes down, 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 so we gotta bring it right back up. You could be swimming or jumping or hanging around, reading or watching TV. A sweet tube feed. A cookie or some Cheez-Its is usually all you need. So we check sugars just in case. It's not convenient, but it's safe. Down and up and up and down. Won't stop till a cure is found. Down and up and up and down. Won't stop till a cure is found. So if your sugar's low and your insulin's high and you don't know why, it might be HI. If your sugar's low and your insulin's high and you don't know why, it might be HI. Sugar goes down, 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 so we gotta bring it up, up, up. Sugar goes down, 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 so we gotta bring it right back up. Thank you guys.
Yay. That was awesome. Jana, thank you so much. What a beautiful song. Really, really inspiring. And with this community, this is the community that won't stop until a cure is found. So we are in this together. And in this period of time, I'm seeing a lot of the slogan of alone together. And so that was something really evident over these 2 days. It's been joyous. It's been fantastic to spend these 2 days together, and it brings so much hope, I think, to know not about all the new treatments that are potentially coming, and also just all the experts who are in this and in this for life and committed to the patients, and also just the amazing families that are living with HI and are also equally as dedicated to making life better for all with hyperinsulinism. And we just have such an incredible community, as you've seen, of advocates all over the world. So we want you all to know that the conference is going to be open for the rest of the week. Most of the sessions will be recorded. You'll be able to visit. And then we have the exhibits. They're just stupendous. There's so much in there. They're just chocked full. It's really the world of HI all in one place. So you should all visit. And I want to thank the CHI staff that has just been so incredible to, make this conference happen, working day and night. Huge shout out to Jennifer Schmidt and Ty Pasquini and Jana Powell and David Hood, who's a volunteer and still works day and night. So you're all just, I don't know, there are no words. Big clap for them. And let's let them all say goodbye. So I'm saying goodbye.
Promotional efforts you would like to do. The line won't stop till a cure is found. That is directly a motivator to join the HI Global Registry. And, I just want to thank everybody again who's been hashtagging ChiFam 2020 from home. It's been so amazing seeing all of your photos, seeing your kids jamming out, seeing people that we wish we could be with. And it really just helps remind us and make it all worth it.
Okay, signing off.
Bye.
Bye.
Thank you.
Bye.
Thank you.
Bye. Thank you very much.
Bye-bye.
Thank you. Bye-bye.